All right, next up we have Chris Economos, Senior Vice President at Echo Health, who will be telling us about embedding AI into trusted clinical tools to better detect and monitor diseases.
Thanks, Lauren. And thank you to BMS for the opportunity to be here today. I'm Chris Economos. I'm with Echo Health, and we're bringing AI to the point of care with the digital stethoscope. So the problem that we solve, every day in pretty much every clinical exam throughout the world, clinicians are faced with a multitude of data points that they have to process in order to determine what's wrong with this patient and answer the question, what do I do next? And it seems pretty straightforward, but very often these data include nonspecific symptoms that can confound the differential diagnosis for that clinician. Symptoms like shortness of breath, exercise intolerance, fatigue, really vague things that make it really difficult for a clinician to know, is this an issue with cardiac function or is it an issue with respiratory function? And so when dealing with that, as you might imagine, and totally understandable, a lot of times these clinicians get this wrong. And as a result, patients are sent to the wrong place, and they have to follow a series of tests to ultimately get to the answer. And by being passed around, it adds to patient burden, cost, and this really long path to finding out what's actually wrong with the patient. So an example of this is in pulmonary fibrosis, where you have a patient, ex-smoker, they'll show up to their primary care physician explaining a shortness of breath or similar, and the doc's first instinct is, well, this is probably bronchitis, I'm gonna write an antibiotic. They go through a couple cycles of that, none of it works. They then switch to albuterol inhaler, same thing, no result, until they finally are referred to the pulmonologist who suspects this could be pulmonary fibrosis and orders a CT scan to definitively diagnose the condition. But this takes a really long time for the majority of patients with the disease. And it's not unique to pulmonary fibrosis. If we look at a ton of the major cardiopulmonary chronic conditions out there, we see real delays in the diagnostic pathway. Heart failure. Almost 2/3 of patients with heart failure are diagnosed in the context of a hospitalization or an acute care event. That is, it's not until they exacerbate that the clinicians actually understand what's going on with these patients. ILD, about 50% of patients are diagnosed after over a year after symptom onset. Valvular heart disease. About half the patients out there with VHD are walking around without knowing that they've got the disease. COPD, same idea. Pulmonary hypertension can take up to 3 years to diagnose pulmonary hypertension. And for hypertrophic cardiomyopathy, the vast majority of patients with HCM are walking around and don't even know it. And so a couple things in common. First, all of these conditions, there's a direct correlation between patient outcomes and how quickly these diseases are diagnosed. The quicker they're diagnosed, the quicker on therapy, the better the outcomes. Second thing that these all have in common is each of these have signals in the heart sounds or lung sounds and ECG of that patient that we can tap into to determine whether or not this patient has the disease. So at Echo, what we've done is taken the stethoscope, been around for 200 years, but we digitized it by virtue of digitizing the acoustic signal as well as adding a 3-lead ECG. With a 10-second recording on the chest or on the back, the clinician captures the data, it's sent to the cloud, and it instantaneously, the AI processes the data stream and determines what, if any, abnormality there might be. So our current portfolio of algorithms include things like low ejection fraction heart failure, AFib, structural heart disease. And to bring this to life, we've got a brief video here from one of our health system partners, NCH in Florida.
Every 33 seconds, somebody in the United States dies from heart disease. 68% of patients with heart failure are not diagnosed in the primary care office. And up to 50% of valvular heart disease may be missed in the primary care setting for elderly patients. Sensora is an AI platform which uses a Core or Core 500 stethoscope made by EcoHealth. This allows the physician or provider to examine a patient, collect heart sounds, analyze it through artificial intelligence, and then provide a result to the physician about whether a patient has valvular heart disease, atrial fibrillation, or low ejection fraction using the Core 500 stethoscope.
The mission at NCH is to help people live longer, healthier, and happier lives. We try to catch disease before it spreads too far, so we do a lot in this community for screening purposes. In building our reputation as a top 2% heart hospital in America, the focus has been on teamwork and attracting and retaining the best talent in America to take care of heart disease. The Sensora technology is something we're all proud of. We've attracted and we're retaining top talent, partially because we equip them with the very latest technology.
All right, so the goal there was to share, this is technology that's been around, it's being used every day. As of right now, we've got about 650,000 devices like this one deployed in over 40 countries, I believe, right now. We'll be up to over 250,000 by the end of the year. So that means every year, about 250,000 or 750,000 clinicians are collecting data with this device at the point of care. One of the exciting things to note is a big part of this huge deployment that we've got is via our partnership with 3M Littman, now known as Solventum, who's really given us a ton of heft in terms of being able to get this into the hands of clinicians. In terms of our AI, so we're a hardware company and an AI company. This is the hardware we build. But the AI, our current set of algorithms is up here along with our roadmap. So as I mentioned, low ejection fraction, heart failure, AFib, valvular heart disease. We are currently building AI for pulmonary hypertension, as well as early stages in preserved ejection fraction heart failure. Later this year or early next year, we expect a FDA submission related to our adventitious lung sound classification. So I'll share a little bit more of that here in a moment. Okay, so enough on the background. Let's talk a little bit about clinical data. So this is a study that was performed at Mass Gen Brigham and presented at American Heart Association back in 2024, I believe, or 2023. In this study, which was really unique design, it was a randomized study, 369 patients who were going through MGB in the course of their normal annual visit. Each of them were examined with a traditional stethoscope in the hands of a primary care physician listening for heart murmur, as well as a medical assistant using this device without actually the headphones, right? It was just the chest piece. And the goal was to understand what was the rate of detection of valvular heart disease based on these two different groups. And what we found was that the medical assistant with the AI embedded technology was twice as successful in detecting a structural heart murmur than the primary care physician. Ultimately, this resulted in almost 3 times as many diagnoses of structural heart disease. In this study, which was performed by NCH, who you saw a moment ago, what they did was deployed our technology across a set of their primary care clinics with the goal of identifying more valvular heart disease across their population of patients 50 and over. They ended up examining about 2,600 patients with the technology. Of those 2,600, approximately 680 were flagged positive as having risk of valvular heart disease with our technology. Of those 680, 227 went on to have confirmatory echocardiography. And then you can see what the diagnostic rates were from there. 79 deemed to have moderate to severe VHD, 109 mild, and 39 no findings. And so What they were really focused on was, in this predominantly elderly population, being able to find more disease, and the net results were over 4 times as many patients were referred to echocardiography, and twice as many ended up getting referred to cardiology compared to the year prior. This next study is a really interesting one sponsored by Mayo. This was looking at our low ejection fraction algorithm in the context of perinatal cardiomyopathy. So the investigator here provided the tech to community health workers in Nigeria, where peripartum cardiomyopathy is a pretty significant problem. And it was a randomized study that looked at this technology relative to 12-lead ECG, as 12-lead AI ECG, and then standard of care. And I just want to note, of the 1,000 patients or so who were examined, the stethoscope was able to detect more cardiomyopathy than both the 12-lead AI as well as standard of care in a way that was statistically significant. And so I think that the real exciting thing about this was that if you think about this location, the fact that you can provide tech like this to a community health worker in Nigeria, I think has fairly obvious implications here in the US as it relates to rural health, being able to deploy technology in the home, et cetera. And then lastly, the program I mentioned around adventitious lung sounds, this is all designed around being able to detect respiratory disease, both being able to detect these different lung sounds and then differentiate them, as well as whether or not the sound is present on inspiration or expiration. So whether it's a wheeze or rhonchi or crackle, and whether it's on inspiration or expiration, we'll send a patient down a different path from a diagnostic perspective. And so what we were able to demonstrate here, this is early data, but our initial proof of concept demonstrated really good performance in terms of both detecting that there is an issue as well as differentiating between the different types of sounds. So we are really excited about where we're going and the opportunity to detect more disease, and we appreciate the opportunity to be here today.
Thank you, Chris. And I think we have time for one question.
Thanks, Chris. I actually have 2 questions, if you can answer briefly. One is, considering all the data that you are continuously accumulating, how are you dealing with it for a continuous improvement and iteration of the app? That's one. And the second one, as you see the growth of adoption, and now it's very exciting to hear about the 150,000, if I heard correctly, per year. What has been really the trick that you see in the ecosystem that is allowing you to really get into this ramp up, if you are able to identify it?
Yeah, so when you can put a stethoscope in the hands of clinicians and they can use it in every exam, you can imagine that you get a lot of data very quickly. The really incredible leap that we've been able to make over the last couple of years is use what's referred to as a transformer model to train algorithms using this type of data that's not annotated, right? So we're collecting data, heart and lung sounds, but generally speaking, we're not getting the annotation alongside with it. Historically, that's had limited value in terms of new algorithms, but with transformer models, which uses the same kind of underlying technology as an LLM, we're now able to tap into that to be able to improve or magnify, I should say, the impact of the specific data that we're collecting that is annotated. So it's, in fact, it's represented in our latest FDA submission, this new approach, and it's really unlocking a whole new approach to how we build our AI. With respect to your second question, I think it comes down to a digital tool that's a familiar form factor, and it fits into the standard of care, right? Every clinician out there pretty much has a stethoscope. And so what's been paramount for us is to be able to do this in a way that fits into workflow. And we find that if you can fit into workflow, you can collect data. And I think that is really what's driving the uptake. Beyond that, it's just a better stethoscope, right? Noise reduction and sound amplification, clinicians just want to use it more. And so I think this is what is driving our success there.
Wonderful.
thank you.
Thank you, Chris.